Let's talk about the consequences of portal hypertension. Now, our portal system is going to be very close to our systemic circulation at 4 regions. And I'm going to circle these 4 regions now. And at these sites, when there is portal hypertension, it is going to result in pathologies. Normally, the portal system does not communicate with our systemic circulation. There's going to be either minimal or no blood flow at these regions. But the problem with portal hypertension is that we're going to have such an increase in pressure in our hepatic vein that there's going to be a backflow of blood into our systemic circulation. And this most commonly occurs with liver cirrhosis. Normally, our liver is made up of soft, elastic tissue, and in liver cirrhosis, this tissue is going to become harder. As a result, it is going to make harder for venous blood to travel through. What is going to happen is there's going to be a backflow of that blood into areas of low pressure. And the areas of low pressure is going to be at these 4 sites. And this is the reason why we're going to see pathologies at these 4 sites. Now, in the first region, which is in the distal esophagus, our systemic circulation contains the azygos vein, and our portal system is going to contain the left gastric vein. And in portal hypertension, blood is going to flow from the left gastric vein to the azygos vein, and this is going to result in esophageal varices. Because the azygos vein is going to receive more blood than usual, those venules are going to dilate, and then they're going to create these varices. And with increased enough pressure, as you can see here, with increased enough pressure, these varices can rupture, and it could cause massive bleeding, which can result in death. 50% of the patients who get diagnosed with liver cirrhosis, they're going to have esophageal varices at the time of their diagnosis. And the rupture of these varices is actually the most common cause of death for patients with liver cirrhosis. So it is extremely important that it is treated properly. The way we treat this is through tying this tube around the varices. And basically this is going to mechanically destroy that varice, and then we're going to have an ulcer that is going to be healed by our body. So ligation is the most common form of treatment. Now, if you take a look at our second location, we have the umbilical veins in our portal system that are communicating with the superficial epigastric veins of our systemic circulation. And with portal hypertension, we're going to have that flow of blood from the umbilical veins into our superficial epigastric veins. And this is going to result in caput medusae. And we see the caput medusae over here. You see how these veins are dilated? Well, it's because we're going to have blood in our interior abdomen through the superficial epigastric veins that is usually not there, so it's going to result in the dilation of these veins, and we're going to be able to visibly see it in patients. And the third location that we're going to talk about is in our colon. The colonic veins in our that are part of our portal system is going to communicate with the left retroperitoneal vein in our systemic circulation. And When we have portal hypertension, this is going to result in retroperitoneal bleeding, and it could also result in colonic varices. And here we see a retroperitoneal bleed, and the areas of high density indicate that there could still be bleeding going on. And the last location that we're going to talk about is found in our rectum, and it is going to be with our superior rectal veins that are part of our portal system, that are close to the middle and inferior rectal veins that are part of our systemic circulation. And with portal hypertension, we're going to get that blood flow from the superior rectal vein to our middle and inferior rectal vein, and that is going to result in hemorrhoids as well as rectal varices. And here we see an image of an external hemorrhoid. If a patient has an internal hemorrhoid, those are usually asymptomatic, but external hemorrhoids like these is going to be very painful. Now, another form of treatment for esophageal varices that we need to talk about is transjugular intrahepatic portasystemic shunt. And this is going to basically connect the portal vein with the hepatic vein. So because we have such a high pressure in our portal vein, in order to decrease that pressure, we're going to try to make another route for that blood to travel to, and we're going to do that through connecting to our hepatic vein, which is then going to take that blood to our heart. And this is an extremely effective way to treat portal hypertension. It is very effective in reducing portal hypertension. But the problem with this treatment is because it is going to direct away such large amounts of blood that our liver is not going to be able to detoxify ammonia. That is one of the major functions of our liver. It is to convert ammonia to urea. Then we're going to be able to excrete urea in our urine. But if we're directing a lot of blood from our liver to hepatic vein and to our circulation, that is going to lead to an increase in ammonia in our blood, and that could result in hepatic encephalopathy. So this is why this is not considered the first line treatment is for esophageal varices. Ligation is considered the number one treatment option right now.